welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EMED-PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
So today I'll be presenting on the comparison of nebulized ketamine to intravenous subdissociative dose ketamine for the treatment of painful conditions in the emergency department. And I have no relevant disclosures related to the content of this presentation. And for the objectives that I hope to accomplish from today's presentation, we will discuss the mechanism of action and indications for ketamine use in the management of pain and review the previous literature comparing nebulized versus IV ketamine, as well as evaluate a recently published study comparing nebulized versus IV subdissociative dose ketamine for acute pain. And to get started with some background, ketamine is an NMDA antagonist. It was approved as a dissociative anesthetic agent to provide analgesia in acute pain. It also stimulates opioid receptors within the insular cortex, the putamen, and the thalamus, which contributes to its analgesic properties. And systemically, it increases sympathetic tone. So this makes it the preferred agent for inductions of anesthesia or analgesia in patients with hemodynamic compromise. And ketamine has been used as a non-opioid alternative for chronic pain syndrome. So our subdissociative IV ketamine doses ranges from 0.1 to 0.3 mg per kg with a max of 30 milligrams. And it can be administered monotherapy or as an adjunct, and it's known to effectively manage pain in various acute settings in the ED and pre-hospital settings. Now, to briefly go over the pharmacokinetics of ketamine, it can be administered through IV, IM, intranasal, and orally. And we can see that the route of administration, each route has a pretty quick onset. It's highly lipid soluble and has a low plasma protein binding. It's also hepatically metabolized, and one of its active metabolite is norketamine, and it's excreted through the urine. So for today, not only will we be talking about IV ketamine, but also nebulized ketamine, which has a bioavailability between 20 to 40% of the IV route with an inhalation duration of 20 to 40 minutes. So nebulized ketamine has been explored in different areas such as palliative care or asthma treatment and post-surgical sore throat relief, but its effectiveness and safety for managing acute pain is currently limited to case reports and case series that really assess the analgesic efficacy, but from these small case reports, it has demonstrated pain without serious adverse effects. And for the safety profile, ketamine may cause side effects such as hypersalivation, emergence reactions, laryngeal spasms, and hypoxia or hypercarbia. Now, moving on to previous literature on nebulized ketamine, Dove and colleagues compared nebulized ketamine at 3 different dosing regimens for treating painful conditions in the ED. And the objective of this study was to assess and compare the analgesic efficacies and adverse effects of ketamine administered through a breath-actuated nebulizers at 3 different dosing regimens. So this was a single-center, prospective, randomized, double-blinded superiority clinical trial that included adult patients with moderate to severe acute and chronic pain and an exacerbation of chronic painful conditions with an initial pain score of 5. And they enrolled about 120 patients, so 40 patients per group, and each patient in each group either received 0.75, 1, or 1.5 mg per kg of nebulized ketamine. The primary outcome was the difference in pain scores on an 11-point numeric rating scales, in which they used a minimal clinically significant difference in pain score of 1.3 between 3 groups at 30 minutes to detect a significant difference. And the secondary outcomes include the need for rescue agents. So a second or third dose of nebulized ketamine or another dose of IV morphine, 0.1 mg per kg at 30 to 60 minutes. Additional secondary outcomes was the number of adverse events at 30 and 60 minutes. And from this study, they found no significant differences in the average pain scores between the three groups at 30 minutes post-treatment. The mean pain score was 4, and all groups experienced a clinically significant reduction of more than 1.3 points from baseline. And from this study, 15 patients in all groups did receive rescue analgesia, but the most requiring rescue medication was the group who receives 1 mg per kg of nebulized ketamine. And from this study, there is no serious adverse events. So this brings us to the article that we'll be talking about today, which is the comparison of nebulized ketamine to IV subdissociative dose ketamine for treating acute painful conditions in the emergency department. This was a single-center, prospective, randomized, double-blind, double-dummy superiority trial that aimed to determine which ketamine regimen is superior for treating moderate to severe acute pain. So patients either receive 0.75 mg per kg versus nebulized versus 0.3 mg per kg IV ketamine. And similar to the previous study that we went over, they included adult patients with a numerical rating pain score of greater than 5, and patients were either randomized to receive IV or nebulized ketamine. So for the patients they included adult patients greater than 18 years old with acute painful conditions such as abdominal pain, flank, back pain, musculoskeletal pain, and headache. And patients needed to have an initial pain score of greater than 5, and they had to be awake, alert, and oriented to person, place, and time, and demonstrate understanding of informed consent and its content. Patients were excluded if they had painful conditions that required immediate interventions by the treating physician, if they were altered or had unstable vital signs, or if they had a history of acute intoxication or alcohol or drug abuse. Patients were also excluded if they had an allergy to ketamine, an actual body weight greater than 150 kilos, and unable to provide consent. Pregnant or breastfeeding women were also excluded from this study. For the interventions, patients were either randomized to receive nebulized ketamine at 0.75 mg per kg given over 5 to 15 minutes, plus a placebo of an IV solution over 15 minutes, or patients receive IV ketamine at 0.3 mg per kg given over 15 minutes, plus a placebo nebulizer given over 5 to 15 minutes. The primary outcome of this study was a difference in pain scores on a numerical rating scale, so 0 to 10, between groups at 30 minutes post-medication administration. And secondary outcomes included the need for rescue analgesia or IV morphine at 0.1 mg per kg, the occurrence of adverse events, and the difference in pain scores at 15 minutes up to 120 minutes. For the statistical analysis, because this study aimed to determine if nebulized ketamine was superior to IV ketamine, the primary data analysis of the pain scores were based on the intention to treat principle, and a clinically important difference was defined as a pain reduction of at least 1.3 points on the numeric rating scale. And to ensure sufficient statistical power, the study required 134 patients total, so 67 per group. And the study design provided an 80% power to detect a statistically significant difference at an alpha of 0.0465 using a one-sided z-test. So to account for any possible missing data, such as early withdrawal, discharge prior to the study comparison, or an absence from the ED due to imaging, they increased the total sample size to 150 patients total. And for the enrollment, from the 221 patients that were approached, 150 patients were enrolled and 75 patients were randomized to the intravenous IV ketamine group or the nebulized ketamine group. For our baseline characteristics, the mean age was 46 years old and the mean pain score between both groups were 8.2. And the most common pain was associated with abdominal, musculoskeletal, and flank pain. Now, looking at the primary outcome, The nebulized ketamine group had a pain reduction from 8.2 to 3.8, whereas the IV ketamine group had a decreased pain from 8.2 to 3.6. So this was not statistically significant, as the main difference was 0.23, and they were looking for a difference of at least 1.3 between the groups. And moving on to the secondary outcomes, starting with the pain scores over time, there was essentially no difference in pain scores at 60 and 20 minutes post-medication administration. For the rescue medications, more patients in the nebulized ketamine group, so 21 patients required rescue medications of either ketorolac, morphine, acetaminophen, or tramadol compared to the IV ketamine group. And although for adverse events, there was no concerning changes in vital signs or any clinical significant adverse effects requiring interventions at any dose or at any time points throughout the study, they found that more patients in the IV ketamine group experienced sedation, restlessness, dizziness, and feelings of unreality for up to 30 minutes post-medication administration. And from this study, it was concluded that there is no differences between ketamine administered IV or through nebulization for short-term treatment of moderate to severe acute pain in adult ED patients. Now let's talk about some of the strengths and limitations of this study. So from this study, I believe it stands out as one of the first randomized controlled trials that directly compared IV and nebulized ketamine for managing acute pain in the ED setting. So this does shed some light on a potentially alternative pain management approach. And in addition, the study had a sufficient statistical power to detect any clinically relevant difference in pain scores between the group. And the primary outcomes and outcomes in general were clinically relevant and patient-centered. And it focused on the difference in pain scores, so that aligns pretty well with patient experience and the treatment successes. So for some of the limitations, this was a single center design, which potentially may not be generalizable to all ED settings with different protocols in place or the available resources to have or perform nebulized ketamine. And in addition, the time spent nebulizing the ketamine solution varied between the participants in this study. So it varied from 5 to 15 minutes, which could have potentially influenced the absorption and impact the observed outcomes. And in addition, there was a significant difference in the amount of rescue medications used for pain relief between the IV and nebulized ketamine group. So this imbalance could have potentially confounded the interpretation of the main results regarding the pain score differences. And to wrap up today's presentation, this study found that sub-dissociative doses of IV ketamine and nebulized ketamine were equally effective in reducing acute pain within the ED setting. And nebulized ketamine presents as a potential alternative route for pain management. So this could be another use for patients where establishing an IV access is challenging or not preferred. And for some future directions, prospective research should investigate standardized protocols for nebulized ketamine administration. So this include determining the optimal dosing and duration of nebulization to further refine its use. And that concludes my presentation. And I'd like to thank Christian Kroll for helping me choose this topic and article for today's presentation, and Ellie Bowers and Brett Benny for helping me with this presentation. And now I'd like to open it up to any questions.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.